بسم الله الرحمن الرحيم.
قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is the fourth and last part of your lecture, Regenerative or Reconstructive Osseous Surgery, presented by Professor Mona Yehia. In addition to bone graft materials, many non-bone graft materials have been tried for restoration of the periodontal. Among them are sclera, dura, cartilage, plaster of Paris, cementoenamel, ceramics, coral-derived materials, and plastic materials. None offers a reliable substitute to bone graft materials. Some of these materials are mentioned here to offer a complete picture of the many attempts that have been made to solve the crucial problems of periodontal regeneration. HTR polymer is a non-resorbable, microporous, biocompatible composite of polymethyl methacrylate and polyhydroxymethyl methacrylate. A clinical 6-month study showed significant defect fill and improved attachment level. Histologically, this material is encapsulated by connective tissue fibers with no evidence of new. The calcium phosphate biomaterials have excellent tissue compatibility and do not elicit an inflammation or foreign body response. These materials are osteoconductive, not osteoinductive. That is to say, they will induce bone formation when placed next to viable bone, but not surrounded by non-bone forming tissues such as skin. There are two types of calcium phosphate material or calcium phosphate ceramics that have been used. The first one is the hydroxyapatite, which has a calcium to phosphate ratio of 1.67, similar to that found in bone material. Hydroxyapatite is generally non-bioresorbable. The second one is a tricalcium phosphate, with calcium to phosphate ratio is 1.5, is mineralogically beta-witlocite. Tricalcium phosphate is partially bioresorbable. The novel forms of bone grafts are present in the form of gel. Composition is 60% granulated mixed plus 40% collagen gel. It is indicated for periodontal regeneration and crestal access. The putty form also has been developed. It is composed of 80% granulated mixed plus 20% collagen gel. Its advantages is due to its malleability and plasticity, which make it easy in application. Also, the collagen facilitates the formation of primary blood clots and subsequent invasion of repairing and regenerative cells. The clinical indications are alveolar regeneration, horizontal augmentation, dehisence, fenestration, and periemption. Case reports and uncontrolled human studies have shown that calcium phosphate bioceramic materials are perfectly tolerated and can result in clinical repair of periodontal lesions. Several controlled studies were performed on the use of Radiograph and calcitite. Clinical results were good, but histologically these materials appeared to be encapsulated by collagen. The following case is a clinical case which show a comparison between the decalcified freeze-dried bone allograft, which is osteoinductive, and the porous hydroxyapatite, which is osteoconductive. This is a facial view of a deep vertical. This is the lingual view of the same defect. The lesion here is filled with decalcified freeze-dried bone allograft mesial in the mesial defect and porous hydroxyapatite in the distal defect. The lingual view also showed that the mesial defect is filled with DFDBA and the distal defect is filled with re-entry after 6 months postoperatively show a total fill of the mesial defect and partial fill of the distal defect. And this is a lingual view at re-entry 6 months post-operative. This is the preoperative radiograph, and this is a radiograph immediately after, and this is a radiograph 6 months later. The bioactive glass consists of sodium and calcium salts, phosphates, and silicon dioxide. For its dental applications, it is used in the form of irregular particles measuring 90 to 170 micrometer and is called perioglass. When the particle size increases to 300 to 355 micrometer, it is known as biograin. When this material comes into contact with tissue fluids, the surface of the particles becomes coated with hydroxycarbonate apatite, incorporates organic ground proteins such as chondroitin sulfate and glycosaminoglycans, and attracts osteoblasts that rapidly form bone. For the coral-derived materials, we have two different coralline materials which are biocompatible and have been used in clinical periodontics. Number one, the natural coral, which is slowly resorbed. It takes several months. The second one is the coral-derived porous hydroxyapatite, which is not resorbed or take years to do so. Clinical studies on these materials showed pocket reduction, attachment gain, and bone level gain. The materials have also been studied in conjunction with membranes with good results. Both materials have demonstrated microscopic cementum formation, but their slow resorbability has hindered clinical success in practice. Regarding the combined techniques for regeneration, the combination of barrier techniques with bone grafts and other methods has been suggested. The following technique has been described by Shalhorn and McLean as follows. First of all, perform a regenerative type of flap. Then the defect is debrided of all granulation tissue and the root surface is planed to remove all remnants of plaque, accretion, and other root surface alterations such as grooves, notches, caries, employing ultrasonic, hand or rotative instrumentation. Odontoplasty and or osteoplasty are performed if required for adequate access to the defect, including intraradicular or furcation fundus concavities and or removal of enamel projections. The bone graft, typically the DFDBA, is prepared in deepened dish, hydrating it with sterile saline or local anesthetic solution, and if there is no contraindications, is combined with tetracycline 125 mg over 25 g of DFDBA. After mixing, the deepened dish is covered with a sterile moistened gauze to prevent dry. The appropriate membrane is selected and trimmed to fit the desired position. Care is taken to avoid contamination. The area is thoroughly cleaned and isolated, and the regenerative site root surface is treated with cotton pellets soaked in citric acid pH 1 for 3 minutes, taking care the solution does not go beyond root and bone surface. If sclerotic bone exists in the graft site, intramarrow penetration is performed with round burr. The ligament surface is scraped with a periodontal probe to remove any scar and stimulate bleeding. The DFDBA is packed firmly in the defect using an overfill approach covering the root trunk and combination confluent vertical dehisence, or horizontal osseous defects. The custom-fitted membrane is placed over the defect and secured as up. The area is rechecked to ensure that adequate graft material remains in the desired area, and the flap is positioned to cover the membrane and secured with non-absorbable sutures. A periodontal dressing is passively applied over the surgical area. Typical peri and post-medication regimens include, if not contraindicated, 7 to 10 days of antibiotic coverage extended with doxycycline, 100 mg daily for 2 to 7 weeks, and analgesic agents. Sutures are removed if and when they become loose or no longer aid in tissue position and wound closure. The patient is seen for monitoring and local debridement as needed every 1 to 2 weeks. If a non-resorbable membrane has been used, it is removed 6 to 8 weeks after operation. This is a pre-treatment photograph of mandibular left posterior teeth with marked recession and tissue inflammation. This case was treated by the combined technique using an osteoinductive bone graft, which is DFDBA, plus the Gore-Tex membrane representing a guided tissue. After flap reflection, we can notice the underlying extensive crestal bone loss, the dehiscence, and the intrabony osseous defect. Decalcified freeze-dried bone allograft is packed in position approximating the cementoenamel junction of the posterior. Then the Gore-Tex membrane is customized and secured over the teeth with Gore-Tex suture. The flap was coronally positioned and secured over the membrane. At the time of membrane removal, a new alveolar bone was observed. This is a pre-treatment radiograph. This is 1 year post-operative radiograph depicting a new alveolar bone. And this is the case pre-treatment view. We can see the severe bone loss, and after membrane removal, we can see the regenerated tissues. Recently, an osteopromotive agents such as the enamel matrix derivative Emdogain with osteoconductive bovine derived and organic bone, bio-os, graft materials, and other combination techniques have been advocated. Notice that the bio-os has been used with bioguide resorbable membrane with successive osseous regeneration and the criteria that guide the choice of treatment technique are: number 1, the dimension and morphology of the defect. The deeper the defect results in greater bone fill. The number of holes in the defect. The 3-wall defects have greater potential to fill than 2 or 1-wall defects. The amount of root surface exposed and the ability to obtain adequate flap coverage. And finally, the angle of the defect to the long axis of the tooth. The smaller the angle, the better chance of success. Foom et al. In 2001 developed the clinical decision tree. For deep, well-contained defects, we use the Emdogain alone with coronally advanced flap if necessary. For moderate to deep non-contained defects, we can use Emdogain with graft and coronally advanced flap if necessary. For supracrestal defects with a shallow vertical defect, Emdogain is used with graft. Tissue engineering with biologic mediators. Naturally, wound healing results in tissue scarring or repair. Using tissue engineering, the wound healing process is manipulated so that tissue regeneration occurs. The manipulation involves one or more of the 3 key elements: the signaling molecule, scaffolds or supporting matrices, and number 3, the cells. The tissue engineer concept is presented here by the pyramids. At the top we have the signaling molecules such as the platelet-derived growth factor or bone morphogenetic proteins, and at the base we have the cells such as osteoblasts or fibroblasts, and the scaffolds, which is maybe calcium phosphate or collagen. Given an appropriate environment and time, regeneration of the tissues and organs will occur successfully. The commercially available tissue engineering systems for periodontal regeneration involve the use of: number 1, enamel matrix derivative with platelet-derived growth factors and beta-tricalcium phosphate. The second one is bone morphogenetic proteins type 1 collagen sponge to enhance periodontal regeneration. These have been studied, but the mixed results and the concern of ankylosis have regulated this differentiation factor to be used primarily for implant site development. Finally, you have the basic fibroblast growth factors, which is another promising system. Note that the use of biologic agents such as enamel matrix derivative and platelet-derived growth factor is a relatively recent concept for periodontal regeneration. The process can proceed even with the short biologic half-life of these materials. This means that it is often not present in the later stages of development. These stimulated cells can somehow organize themselves to differentiate and in a timely fashion become 3 histologic structures: new bone, cementum, and periodontal ligament. It is amazing that these 3 histologic structures intertwine with each other and stimulate regeneration using a different mechanism from the bioexclusion principle, as demonstrated with the use of guided tissue regeneration membranes. The use of biologic agents can stimulate stem cells to be recruited to the intrabony or furcation defect site, proliferate, and differentiate into a newly regenerated periodontal apparatus. It is also interesting that this occurs in a very rapid fashion, faster than the migration of epithelial and mesial. The factors that affect a successful outcome for periodontal regeneration are inadequate plaque control, poor compliance with supportive periodontal therapy, flap design, defect and root morphology, material employed, flap position, and postoperative management. For evaluation of new attachment and bone regeneration, we have several methods. The first one is the clinical method, which consists of comparison of pre- and post-treatment pocket probings and determinations of clinical gingival findings. Clinical determination of attachment level are more useful than strict pocket depths because the latter may change as a result of displacement of the gingival margin. Number 2, the radiographic method, evaluation of bone regeneration, also requires carefully standardized techniques for reproducible positioning of the film and tube. Even with standardized technique, the radiograph does not show the entire topography of the area before and after treatment. Furthermore, thin bone trabeculae may exist before treatment and go undetected radiographically because a certain minimal amount of mineralized tissue must be present to register on the radiograph. Studies with subtraction radiography have enhanced the usefulness of radiographic evaluation. A comparative study between linear measurement, computer-assisted densitometric analysis, and a method combining the two reported that the linear computer-assisted densitometric analysis method offered the highest level of accuracy. The surgical entry of a case after a period of healing can give good view of the state of the bone crest that can be compared with the view taken during the initial surgical intervention and can also be subject to measurement. Models from impressions of the bone taken at the time of the initial surgery and later at re-entry can be used to assess the results of therapy. This method is very useful but has two shortcomings. The first one is it requires a frequently unnecessary second operation, and it does not show the type of attachment that exists, whether it's new attachment or a long junctional epithelium. And finally, we have the histologic methods. The type of attachment can be determined only by the histologic analysis of tissue blocks obtained from the healed area. Although this method can offer clear evidence of regeneration of the attachment apparatus, it is not without problems. The need to remove a tooth with its periodontium after successful treatment limits this method to volunteers who need the extraction for prosthetic or other reasons and agree to the procedures. Animal studies can be used to clarify some aspects of the tissue response to different materials. However, species differences should always be remembered when extrapolation to human are attempted. Finally, those are your references, and I would like to thank you all with all my best wishes. Professor Mona Yehia. Thank you.